Afternoon, everyone. We're just going to allow another minute for people to enter the webinar, and then we'll start the formal webinar. Thanks. There are people still filing in, but we'll get started. So good afternoon, everyone. Thank you for joining this month's webinar titled Pollen and Health in a Changing Climate. I'm Rachel Tham, a Centre for Safe Air Postdoctoral Research Fellow, and I'll be chairing today's webinar. Before we begin, I would like to acknowledge the First Nations people of the lands upon which we all meet today. I'm on the Wurundjeri and Dja Dja lands where I work and live. I pay my respects to elders past and present and to all First Nations people who are here today. I recognise and acknowledge the enduring connection of First Nations people to their lands, water and air, and their ongoing leadership in science, health, sustainability, renewal and celebration. In Wurundjeri language, I say Wominjika, welcome. So today we're covering the health impacts of pollen and other aeroallergens increasing, especially for people with allergies, asthma and other respiratory illnesses. In a rapidly warming climate, pollination seasons are lengthening and extreme weather events are increasing, and we are seeing the spread of pollen into densely populated areas. Today, we are privileged to have two esteemed speakers, Dr. Sabrina Idrose and Professor Joe Douglas, who will shed light on this topic. Each speaker will present for up to 20 minutes, followed by a Q&A at the end of the session. Our first speaker, Sabrina, is also a Centre for Safe Air Postdoctoral Research Fellow based at the Allergy and Lung Health Unit at the University of Melbourne. Sabrina's research focuses on the impacts of aeroallergens, mainly pollen, on allergic diseases and cardiorespiratory health. Sabrina completed her PhD in July 2023, investigating the role of grass pollen in allergic diseases and lung health. To date, Sabrina has 21 publications and has been awarded approximately 490,000 Australian dollars in scholarships, fellowships, grants and awards. Within the Centre for Safe Air, Sabrina is the webinar coordinator and chair. She is also a steering committee member of the Student and Year Research Network and a council member of the Asia Western Pacific chapter of the International Society of Environmental Epidemiology. And Sabrina is going to present us with an overview of the health impacts of pollen, including her own research. Sabrina, are you ready to share your screen?
Yeah, thanks, Rachel. Okay, hopefully you can see my screen. Thanks again, Rachel, for that introduction. So the title of my presentation is Clearing the Air, Can Pollen Do More Than Make You Sneeze? This is my presentation outline. First, I will talk a little bit about pollen and then the impacts of pollen on allergic and non-allergic diseases, the susceptible groups, and take-home messages. So pollen is essentially a male fertilizing component of seed-bearing plants. It is a fine dust-like substance that is usually transported by animals or abiotic factors such as water, rain, and wind. Pollen produced by wind-pollinated plants are usually allergenic, and the three main allergenic pollen families are from grasses, trees, and weeds. The primary pollen differs between countries and regions due to geographical variations. For example, nettleweed pollen is dominant in southern Mediterranean, birch tree pollen is dominant in northern and central Europe, and grass pollen is dominant in Australia. So climate change, such as rising carbon dioxide levels and temperatures, has resulted in increased duration of the pollen season, greater pollen allergenicity and quantity. And so the health impacts of pollen is expected to become progressively worse with climate change. In Australia, grass pollen is a primary aeroallergen, specifically temperate grasses such as from ryegrass and timothy grass. Temperate grasses is prominent in most parts of Australia, such as WA, South Australia, Victoria, ACT, New South Wales, and Tassie. But subtropical grasses, such as Bermuda grasses, are prominent in subtropical regions of Australia, such as Queensland and likely the Northern Territory. This systematic review, which was published in 2018, has shown that grass pollen in general is an important trigger of child and adolescent asthma emergency department presentations. But this other systematic review, which was published several years later, it focused on subtropical grass pollen, and they showed that subtropical grass pollen had little to no effect on asthma emergency department presentations and hospital admissions. And so this led us to conclude that exposure to temperate grass pollen seems to have a stronger effect compared to subtropical grass pollen. So the grass pollen family consists of over 12,000 species. Today, 11 groups of grass pollen allergens have been identified, but the most important ones comes from groups 1 and 5. Groups 1 and 5 allergens are highly conserved in clinically important grasses, and due to their micron sizes, they can penetrate deeper into the airways. And studies have shown that up to 90% of grass pollen allergy individuals have IgE antibody reactivities to these allergens. Besides grass pollen, tree and weed pollen may also be important. These are findings from studies conducted in Sydney, where they showed that tree pollen, specifically cypress, casuarina, and pinus, were detrimental to childhood lung function. And this other study has shown that although boys were more vulnerable to grass pollen, weed and other pollen were also important triggers of asthma exacerbations in children and adolescents. Another thing to note about pollen is the lag effect. So pollen can have a lagged effect on the immune response. What we mean by this is that when you're exposed to pollen, say day 0, the lag 1 is the effect 1 day after exposure. Lag 2 is the effect 2 days after exposure, and lag 3 is the effects 3 days after exposure, and cumulative lag 3 is the cumulative effect of pollen over the 4 days of exposure. We have shown in our previous study that increased grass pollen exposure was associated with increased airway inflammation 1 to 2 days after exposure and lower lung function 2 to 3 days after exposure. So looking at the impact of pollen on allergic diseases, so essentially pollen has a size of between 10 to 70 micrometers, and because of this, they usually get trapped in the upper airways, triggering symptoms of hay fever and conjunctivitis. However, upon contact with water and other climatic conditions, pollen can rupture into smaller particles of less than 10 micrometers, and it can penetrate deeper into our airways, eliciting a more dramatic immune response and triggering symptoms of asthma. So in an allergy immune response, upon inhalation, dendritic cells sample the allergens and then migrate to the lymph nodes and trigger T helper 2 cells. The T helper 2 cells then produce inflammatory cytokines, which then induces an allergy immune response. So it is well known that pollen can trigger asthma and hay fever, and this has been observed in studies looking at hospital presentations, GP consultations, and self-reported symptoms. The studies from these findings collectively have shown a strong evidence of an association between pollen exposure and the above outcomes in both children and adults. Studies have also shown that even low to moderate levels of pollen can trigger symptoms both in the upper and lower airways. And in extreme circumstances, pollen can trigger thunderstorm asthma. And thunderstorm asthma will be covered by Joe in the next talk. So we previously did a systematic review looking at the relationship between outdoor pollen exposure and lung function and airway inflammation within the community. And we found that there were 7 studies that looked at lung function. While there was no evidence of an association in most studies, the one study that did investigate lag effect found a lag effect of up to 7 days between pollen exposure and lower lung function. The studies looking at airway inflammation were more, so there were 23 studies that looked at airway inflammation. And collectively, the studies showed substantial evidence of upper and lower airway inflammation, especially in people with ever hay fever and or ever asthma. The data also reflected predominantly a type 2 immune response, which is an allergic immune response, but there was little evidence to suggest lag effects. However, there were very few studies that investigated lag effects in relation to airway inflammation. We also conducted a meta-analysis, and from the forest plot on the right here, we can see that the eosinophilic inflammatory response may increase with age with increased pollen exposure, and this was observed in people with ever seasonal allergic rhinitis. So pollen can also have an impact on non-allergic diseases. So some studies have shown that pollen do exhibit non-allergenic properties, such as bioactive lipid mediators, which can cause upregulation of polymorphonucleosides, irrespective of sensitization status. In support of a possible non-IgE mediated mechanism, studies have shown some evidence of a relationship between pollen exposure and non-allergic respiratory diseases, such as the chronic obstructive pulmonary disease, COPD, pneumonia, and COVID-19. For COPD, of the 5 studies that investigated the association, 2 reported some evidence of an association. For pneumonia, there was one study that found that increased pollen exposure was associated with an increased risk of pneumonia-associated mortality with increased grass pollen concentrations. We did a review looking at the relationship between pollen and COVID-19 infection, and the findings were mixed. Some studies found that pollen may increase the risk by acting as a virus carrier. Some studies found that pollen may reduce the risk by acting as an inhibiting factor, and some studies even hypothesized that there may be even no effect on the risk of infection because it is difficult to determine if pollen really contributed to the susceptibility of infection or just the expression of symptoms. In regards to food allergy, there's a condition called the pollen food allergy syndrome, which occurs when antibodies to a specific pollen cross-react with food that contains similar proteins to the pollen. And this is usually in people who have sensitization. And long-term studies have shown that pollen exposure in utero and in early life increases the risk of food allergy in later childhood. We did a short-term study looking at the relationship between grass pollen exposure and food skin prick test reactivity in the health nuts cohort, and we found that persistent grass pollen exposure over 4 days may trigger food skin prick test reactivity, but the impact was greater if peanut allergy was already present. So we found that in 1-year-old children, as you can see from the graphical abstract here, increased grass pollen exposure was associated with an increased risk of peanut skin prick test reactivity, but only in infants with a family history of food allergy. But in peanut allergy infants only, increased grass pollen exposure was associated with a lower reaction threshold to oral food challenges and a higher serum food-specific IgE levels. In 6-year-old children, the associations were more general in the sense that increased grass pollen exposure was associated with an increased odds of skin prick test reactivity to all of the food allergens. There are some population-based studies looking at the relationship between pollen exposure and whether it can trigger eczema flares. The ISAC cohort, they found no evidence of an association between pollen exposure and self-reported eczema symptoms in adolescents. But in the health nuts cohort, we did find some evidence of an association between grass pollen exposure and scoret-based eczema flares, which is an objective measure in 6-year-old children. So here in the graphical abstract on the right, you can see that increased grass pollen exposure was associated with a 1.13-fold increased odds of eczema flares in 6-year-old children. Clinical studies have supported these findings, such that direct application of pollen onto the skin can induce eczematous lesions, and both children and adult patients with eczema have more symptoms with increased pollen exposure, and this was observed irrespective of their pollen sensitization status. Other studies have also found a relationship between pollen exposure and cardiovascular health outcomes. So all of these 3 studies found an association between pollen exposure and cardiovascular health outcomes, including mortality and hospital admissions, as well as ED presentations. The proposed mechanism for this association is a heightened inflammatory response following pollen exposure. It is likely that cardiopulmonary related health effects arise due to immune defense reactions occurring with endpoints inside and outside the respiratory system, including the heart. And some studies also found an association with mental health outcomes. So Bergman's et al., that was published in 2021, found that short-term distress was higher in 3 pollen allergic patients than in the general population. According to the authors, allergies may disrupt sleep and affect cognitive function and thus exacerbate emotional distress. They found that residential green space did have a protective effect against the short-term distress, but the distress was higher if the patients reported perceived presence of allergenic trees near their residence. According to the authors, perceived pollen exposure can lead to emotional distress, and this can lead to allergy symptoms. However, allergy symptoms can lead to stress, and then stress then worsens the allergy symptoms. So this is like a feedback loop mechanism. Another study found that grass pollen was associated with same-day suicide for women and those with a lower education level. They proposed that women are more susceptible to inflammation-induced mood changes and related depression. And lower educational level is a proxy for lower socioeconomic status. Individuals who have lower SES may have a higher burden of chronic conditions, which may then increase their susceptibility towards pollen exposure and mental health issues. So moving on to the susceptible groups. So we did this review looking at the current literature to identify who were in the susceptible groups, and we found that people with asthma, allergic rhinitis or hay fever, and pollen sensitization were well known to be susceptible to outdoor pollen exposure. And there were other groups that have been studied, but it requires further research because I guess more studies need to support these findings, as there were little studies that have investigated these subgroups. So the group that have a potentially low risk are girls if there were children and men if there were adults, so there's a sex shift there. People with higher socioeconomic status, people who have good adherence to medications, and people with low residential greenness. The associations with air pollutants and age are a bit mixed, and some studies have shown that Blacks and overseas-born Asians, people with eczema, food allergy, or human rhinovirus infection are potentially at high risk of respiratory deficits when exposed to outdoor pollen exposure. We recently conducted a study looking at middle-aged adults of the Tasmanian longitudinal health study cohort. And we found that smokers with allergic respiratory disease, people with higher traffic-related air pollution exposure, those with combined allergic phenotypes such as people with asthma plus hay fever, asthma plus eczema, and so on, and also people with allergic respiratory disease who did not use inhaled corticosteroids recently were at higher risk of lower lung function in the grass pollen season compared to the same groups tested out of the grass pollen season. So the take-home message here is that pollen is an important trigger of asthma and allergic rhinitis. The established susceptible groups are people with pre-existing respiratory conditions and sensitization. However, the evidence on other outcomes in susceptible groups are still lacking. But we believe that the health implications of aeroallergens, specifically pollen, may be more serious than previously thought. So the burning question is, can pollen do more than make you sneeze? I think yes. Just to inform that my postdoc work within the Center for Safe Air aims to look at the relationship between aeroallergen exposure, which includes fungi in addition to pollen, and cardiorespiratory health effects within the community, and then developing innovative tools for predicting its risk. So hopefully I'll have some results for this project soon, and I'll be able to present again at the webinar. Before I end my talk, I'd just like to acknowledge the Center for Safe Air and the Allergy and Lung Health Unit, as well as my collaborators. Thank you so much.
Thank you, Sabrina. Sorry, I had trouble unlocking my keyboard then. Yep. Sorry. So if you have questions for Sabrina, could you pop them into the Q&A chat section? And those questions will be asked and answered after Joe's presentation. I'm sure that presentation provoked a lot of questions from you. It certainly did for me. So now I'd like to introduce Joe. Joe Douglas is a specialist physician in respiratory medicine and allergic disease. Since January 2020, she has held the James Stewart Chair of Medicine at the University of Melbourne at the Royal Melbourne Hospital, where she is also Director of Research. Joe graduated in medicine from Monash University, Australia, with specialist physician qualifications from Australia and the UK. She has led clinical services in allergy and clinical immunology at the Royal Melbourne Hospital. Her MD has led to a research career with over 150 publications in asthma, therapeutics, allergic disease, and immune disorders. Her current research focus is allergic and thunderstorm asthma, which is funded by the Medical Research Future Fund. She is a former president of the Australasian Society of Clinical Immunology and Allergy, ASCIA, co-chair of the Australian Immunodeficiency Strategy from 2019 to 2022, and serves on numerous government, industry, and consumer-led advisory boards. In recognition of her contributions to the community research and clinical practice, Jo was awarded the Office of the Order of Australia in the 2024 King's Birthday Honours. So Jo is going to talk with us today about thunderstorm asthma and the studies that she leads on thunderstorm asthma, namely the TASER and CARISTA at this stage. Jo, are you able to share your screen?
I'm hoping that's working.
That is working. Thank you, Jo.
Excellent. Thank you for such a kind introduction, and thank you very much for giving me the opportunity to share some of our work with you today, and to such an important audience who can really take home the message of pollens and asthma and respiratory disease. Also, Sabrina did a wonderful job telling you some of the information specifically with respect to pollens, because pollens are often a poor cousin of respiratory triggers. We know about viruses and we know about asthma and COPD, but there's often pollens are not thought of as being so important in terms of respiratory disease. So I'm hoping to change your perception of that in the next 20 minutes. So with that, I just wanted to give you some declarations and talk a little bit about our current study, which is the CARISTA study. And along the way, I want to talk about thunderstorm asthma and particularly treatable traits in thunderstorm asthma and risk factors for asthma occurring in those with allergic rhinitis and how a CARISTA study might help us on the journey. So I want to start then by thinking about thunderstorm asthma. Some of you may have been around on the 21st of November 2016 when a thunderstorm rolled over Melbourne in the evening. And I remember I was actually leaving work at the time and watching this storm front come across. And it was the third day in a row of high pollen counts, the third hot day with temperatures above 30 degrees in the third week of November. And in this thunderstorm came across, we know a lot about thunderstorms and the aerobiology and the meteorology of them. We know that what thunderstorms are is a huge biomass drawn up into the clouds from into the thunderstorm storm front at the differential between high and low pressure systems. And that biomass is drawn up and accumulated. And in Victoria, we have a particularly fertile geography for this, with huge pastures across to the west, which are filled with imported temperate grass pollens for the pasture, and which have very high pollen production. And so the geography of Melbourne particularly, but also most of Southeast Australia, is particularly prone to these because a lot of pollen can be sucked up into the clouds. And at the front of a thunderstorm, at the convergence of the high and low pressure systems, there's a rapid downdraft of the particles which have been sucked up, this biomass, and that leads to a very high exposure of individuals to pollen and pollen fragments. And the important point is that, of course, thunderstorms are usually a time of rapidly increasing humidity, which is exactly what pollen grains are meant to detect, and they burst in this. So not only are the exterior of the pollen grains floating in the air to be inhaled, but the particles within the pollen grains. And we'll talk about that in a few minutes, about how important that might be to people having thunderstorm asthma. Because as Sabrina has already pointed out to you, these beautiful pollen grains sit here and are around up to 70 microns, usually around 20 microns in diameter. But when exposed to humidity, they can rupture and these tiny granules emerge. And a very old experiment now, I suspect it might have trouble getting ethics these days, but we shouldn't lose the data. Intact pollen grains, and Kentucky bluegrass is closely related to ryegrass. It's a species of temperate grass. Intact pollen grains can be breathed in, and these were labelled and mostly located in the upper airway. We don't perhaps always think that our pharynx, our upper airway, is a very good filter and humidifier of air, such that below the larynx, almost all the air that comes down is filtered from particles greater than 2.5 microns, and it's also perfectly warmed and humidified. However, when they exposed these individuals to the ruptured, to pollen grains that had been exposed to increased humidity and therefore ruptured, you can see that these smaller particles were readily respirable to the lower airways, hence leading to an understanding of what might actually generate the thunderstorm asthma events that we can see. So on the 21st of November 2016, a big storm passed over Melbourne from the west, as is typical of our thunderstorms. And within 30 hours, there was over a nearly seven-fold increase of excess respiratory related emergency department presentations. You can see here this absolute surge of calls to the ambulance, which, if you are mindful of the inquiries which have subsequently occurred, overwhelmed our emergency services. So there were no ambulances available to acutely treat people. People were queuing up outside local pharmacies. Many of them were queuing outside hospitals. And unfortunately, in that time, 10 people succumbed to asthma, many of them associated with this delay of being able to attend emergency facilities. There was also increase in hospitalizations, nearly fivefold, and 44 of those went to intensive care. Normally that number is about 1/10 of that. So this was the most severe thunderstorm asthma epidemic that had ever been recorded. It was far from the first, and Victoria has reported at least 10 since the first report in 1984. So they do tend to occur every 5 to 7 years. And they're obviously environmental health emergencies and sentinel events in many ways. But I would also like to turn this on its head and say that thunderstorm asthma is not the only seasonal asthma that we see. This is aggregate data from 25 years of emergency department presentations with acute asthma in all age groups, 0 to 85, from the Victorian admitted data set. And it's done by admissions per 100,000, looking over the year trajectory. And a pattern emerges, which is similar to that that has been reported internationally, but with some important specific local differences. So you can see here a February-March peak, which is often described as the children going back to school. And so not surprisingly, we see this very large in the 0 to 19-year-old age group associated with virus infections. We see a winter peak, which is in children and in older age groups particularly, so the winter viral peak with particularly influenza and other winter viruses being important. And here, peculiarly in Victoria or in Victoria and internationally significant is this peak October, November, December, which is of course our grass pollen season. So this study also looked at the cumulative incidence of high asthma admission days and showed that they were particularly focused on this time. It's also important to note that in the 65-year-old plus group, we don't see this seasonal surge. So it's in young people and adults. So this leads me to say that whilst we all know about thunderstorm asthma and we can all be alerted to the possibilities of thunderstorm asthma and its terrible and tragic mortality and morbidity and the threat to society and our health system that proposes, in fact, there is an annual surge of asthma admissions that is very reliable over the October, November, December period in Victoria that has around at least fourfold increase from baseline presentations in seasonal asthma presentations. And we could call this, if you like, seasonal allergic asthma or ryegrass pollen associated morbidity. And on top of that, we've come to know that this is on top of a very large community burden of seasonal allergic rhinitis. And so whilst we think that rhinitis or hay fever isn't so important, it doesn't kill anybody, and certainly a lot of clinicians say that, you can see from Sabrina's talk, previous talk, and also from this data, that ryegrass pollen associated morbidity with respect to lower respiratory disease is really important. So if we're thinking of this thunderstorm asthma as just the tip of the iceberg, what are the potential biomarkers that we might be able to identify to give us some insight as to the risk factors for developing more severe disease from those who have only hay fever? And I want to talk about that in the following 15 minutes or so related to my talk. I'd also like to give you a perspective as a respiratory physician, because one of the trends in respiratory medicine in the past decade has been is to understand firstly that all asthma is not just asthma, or all respiratory obstructive disease, asthma and COPD, which are closely related conditions, are not really in aggregate the same diseases, and in many individuals have differing traits amongst them that actually can lead to increased risk of exacerbations. And there are studies looking, and if we actually identify treatable traits and address them, and these studies particularly come out of Newcastle, being led by Vanessa McDonald, the Director of Research at the Hunter Medical Research Institute, that in fact addressing each of these treatable traits can make a big difference to individual prevalence of exacerbations, both at a community, in cohort studies and at an individual level. And so this is the preferred approach for treating significant asthma. But of course, as someone who's related to allergy, I look at this and think there's no allergy there. And I think we should be thinking of pollen as a potential, and pollen sensitivity and allergies as a potential treatable trait, and hence the thesis of this talk. So if we go back to the 2021 event and 2016 event and look at those who came to hospital, this work was done by phone survey led by Frank Tan from Eastern Health. And they managed to phone over 1,400 individuals who presented to hospital across Victoria in the setting of that 2016 thunderstorm asthma event. And what they showed was that about 40% knew that they had asthma at presentation. About 2/3, though, when closely questioned, had asthma symptoms. There was an overrepresentation of individuals with Indian or Asian ethnicity especially if they were first-generation Australian born. The other points to notice was that previous asthma and hospital admissions were a risk factor for presentations. So that gives us a pretty big clue that both thunderstorm asthma and perhaps seasonal asthma is related to previous asthma and asthma symptoms in those with hay fever. But one of the things that came out of the further analysis of this study, and which has been confirmed by our own data, is that rhinitis severity in no way predicted likelihood of hospital presentation in this study and also in our TASAR study. So it does seem that severity of hay fever is not an indicator we can reliably use in the clinical domain to predict or potentially predict severity of thunderstorm asthma or allergic asthma. So this is data from the Royal Melbourne Hospital collected after the 2016 event and looked at those who were sent home from the hospital, sent home from emergency department versus those who were hospitalised, and looked at their ryegrass-specific IgE, the allergic antibody to IgE, and looked at its level. And there's a signal here, whilst not significant, that those who were admitted to hospital had higher levels of allergic sensitisation. This could inform a hypothesis that perhaps higher levels of allergic sensitisation, an easy test, easily available in general practice, could be a potential biomarker of risk for seasonal thunderstorm or allergic asthma. So what are doctors supposed to do? Some have said that there is a trifecta of having hay fever, seasonal allergic rhinitis, together with ryegrass pollen allergic sensitisation and exposure to the storm is the risk factor for thunderstorm asthma. So all these people should get asthma treatment to keep themselves safe. But of course, allergic rhinitis or hay fever occurs in 1 in 5 people. That is not going to happen easily. We're not going to convince 1 in 5 people to take asthma treatment or have it available in the springtime. So clinicians need to do better to actually identify risk in individuals so that we can actually institute preventive asthma and allergy treatments and keep people safe. I should also mention that being the public health alerts of staying indoors and avoiding storms is also very pertinent here, but I'm not going to deal with that any further. So how can we identify risk to actually identify those at greater risk of lower respiratory disease of asthma in the setting of pollen exposure and potential thunderstorm asthma? So to do that, we set up the TASAR study, which is a study identifying risk for thunderstorm asthma in severe allergic rhinitis, recruiting over 200 people in the 2018 pollen season, and for the first time collecting physiological and questionnaire data, including biobanking samples, and then also prospectively following them through the 2018 and 19 season for symptoms of hay fever and asthma. This is the demographics, and the good thing about the TASAR study, which fell out, is that we're able to collect in a roughly third distribution those with seasonal allergic rhinitis only who complained of no symptoms of thunderstorm asthma despite being around in the 21st November 2016. Those who had thunderstorm asthma symptoms but did not need emergency medical care, and those who presented to hospital with thunderstorm asthma. And you can see there's a number of demographics about those that might be important. In particular, males were overrepresented in the group that was more severe. They were those who were born, parents of birth were outside Australia were in reduced number in those who had more severe presentations. And asthma control was much worse in the group who had been in hospital, despite this being taken nearly 18 months after the sentinel event. So we then purported that there could be biomarkers of risk for presenting with asthma, both for thunderstorm asthma, and obviously the first candidate was ryegrass-specific IgE. And you can see in these 3 groups that we described before, hay fever only, thunderstorm asthma symptoms, needing emergency treatment for thunderstorm asthma, there appears to be a gradient of increased ryegrass-specific IgE in those who had thunderstorm asthma and required hospitalisation. In those, we also looked at 3 other biomarkers that might be useful clinically. One was exhaled nitric oxide, an index of inflammation in the airways that's particularly associated with type 2 inflammation and eosinophilic recruitment, eosinophils being allergic cells. We looked at blood counts of eosinophils because one of the biomarkers that you will have seen in the treatable traits is blood eosinophils are a well-recognised biomarker for exacerbations. And there's certainly a trend here to be increased in those with more severe disease. And the fourth biomarker we looked at was low lung function as forced expiratory volume in 1 second following bronchodilator. And you can see that those who presented to hospital had significantly lower lung function than the milder group. So we then analysed this, and this was done in a rock curve with Carolyn Lodge, leading this work, in particular looking at blood eosinophil count, ryegrass-specific IgE, and these 4 biomarkers. And we're able then to have create a Uden index, a cut point at the Uden index, and a sensitivity and specificity at those points, looking at those 4 biomarkers. The best performing of them was the ryegrass-specific IgE with a threshold of 10.1, very high level, but still clearly positive, but still as an indicator with a sensitivity of 0.84 and a specificity of 0.57 for presenting with thunderstorm asthma in this admittedly retrospective study. And practically that would be a very feasible test to implement in community practice, whereas these others are not so available. And whilst eosinophils are useful and available, their cut point is quite low, and specificity and sensitivity not as well performing as ryegrass-specific IgE. So we thought, well, we did have data on those who unfortunately died in the thunderstorm asthma event from the coroner's court, and we were able to see that in that group, the ryegrass-specific IgE was 53, easily greater than the 10 threshold identified in our previous study, suggesting that this could, at least at its extremes, have some utility as a clinical biomarker of risk. The other point to say was that those who died, all of them had a previous asthma diagnosis, and I think that's an important indicator too, which we might usefully institute preventive treatment for in the setting of thunderstorm asthma risk. So we also followed individuals with an air rater app from Faye Johnson's group at the time to monitor symptoms. And in particular, we looked at grass pollen exposure and rhinitis symptoms. And you can see, and this was over the subsequent 2 grass pollen seasons for these individuals, 18 and 19, and looking at symptoms of rhinitis reported in the app at exposure levels of grains of pollen per metre cubed of 20, which is fairly low, 35 moderate, and 50, which is considered high to extreme. And if you look here, there is certainly an immediate response with rhinitis symptoms at day 0 and also day 1. But day 3, by day 3 lag, and Sabrina's already taken you through this, in our data, there was not really a real carryover of upper airway symptoms. But the important point about this is it's quite in contrast to the pattern in the same reports to grass pollen and asthma symptoms. So if we looked at here the high to extreme grass pollen counts at day 0, there was a significant increase in asthma symptoms, which then fell back to 0, but then again increased substantially at day 3. And whilst this data set is not huge and we can't usefully probably isolate risk factors for it, it does point to an unappreciated reality of grass pollen exposure and lower airway symptoms occurring in day 3, and confirming much of Sabrina's work that she reported in analysis from her studies. So we think this is important in an area that hasn't perhaps been examined before. It's also relevant that thunderstorm asthma, generally speaking, if one looks historically at thunderstorm asthma events, they occur after a sequence of high pollen days, generally the 3rd day. So that also gives us information about when we should be warning. So just to go into the group 1 and group 5 allergens, which Sabrina touched on in the previous talk, group allergens, major allergens of any allergenic compound, are those that greater than 50% of individuals who are allergic are sensitized to. And with grass pollens, there are 2 that are really important. The group 1 allergens, which is present on both the subtropical and temperate grasses, and the group 5 allergens, which are present on the sub-pollen granules that you can see. But interestingly, the group 5 granules, the group 1 has a great deal of homology across a large number of species of grass, so that someone who is sensitized to ryegrass will highly likely be sensitized to Bermuda and indeed Bahia as well. But the group 5 allergens are much more species specific. And for example, even in the relatively closely related grasses of timothy and rye, the group 5 allergen homology is only 65%. So that means that the group 5 allergens are much more species specific, which might be one of the reasons why Victoria suffers so badly from thunderstorm asthma, because of the ryegrass pollen that it's been exposed to. I also should point out that the subtropical allergens don't contain the subtropical grasses don't contain group 5 allergens. So we're really looking at the temperate grasses here. So a question arises then, could group 5 allergen sensitivity be a better indicator of risk for lower respiratory disease than the group 1 allergens, which are only contained on the exterior of the pollen grain? So this has been looked at. This is work from Robin O'Hare's laboratory and Mark Hugh from the Alfred Hospital, who looked at individuals who had, who did not have and who did have epidemic thunderstorm asthma in a study they were conducting. And they looked at IgE to LOLP1, that's the group 1 allergen on the outside of ryegrass pollen grains, to a recombinant LOLP5 allergen, and showed that that was had a significant difference in those who'd experienced thunderstorm asthma versus those who didn't. And that was replicated in the total IgE to native grass pollen allergens in a laboratory test. So in their work, the total ryegrass pollen test functioned perhaps better in the rock curves that we can see, but confirming the theory about the burst pollen grains being important to thunderstorm asthma, LOLP1 sensitivity was was the least useful of the potential predictors. I should also mention that component resolved diagnostics, which is what this is about, is a major area of interest of allergic disease and is being used in food allergy to great effect to increase or decrease the risk factors for things like peanut anaphylaxis, cashew anaphylaxis, but is yet to be exploited in respiratory allergies. But the potential is there for therapeutic utility. So we went back and looked at the TASAR cohort in this way using purified LOLP1 and LOLP5 allergens, and we used the 3 groups, the mild, the moderate, if you like, and the severe group with hospital admission. And there did appear to be some indication of increase, particularly with LOLP5 with severity, indicating this could be a marker. And when Rachel Tham further analysed this data, which was provided to us from Janet Davies, who analysed the TASAR cohort sera for these, what she showed was if you look at the odds ratio for an interquartile of presentation with thunderstorm asthma for an interquartile range change in ryegrass specific IgE or subcomponent IgE, you can see that both in the raw and adjusted odds ratio, the LOLP5 specific IgE performed significantly and very well, similar to the ryegrass specific IgE, but probably better. And if we look at the presentation with any thunderstorm asthma, so grouping the 2 groups who had asthma compared to the baseline seasonal allergic rhinitis only, you can see also that the LOLP5, looking for those sensitivity to the particles, had a high risk factor that was certainly equivalent total to ryegrass specific IgE. And again, LOLP1 was not particularly significant. So where to now? We need to refine risk factors more, and component resolved diagnostics could be something we could do. And I'd really like to see allergy considered alongside other treatable traits as something for clinicians can address. And so with Rachel Tham, we have been successful in securing funding for a prospective study to evaluate the biomarkers that we identified retrospectively in TASAR. And we're planning in the next couple of years to recruit 400 individuals with allergic rhinitis and ryegrass pollen sensitisation to collect the initial demographic symptomatic data and to follow them for 2 years using a customised app or website for symptoms and linking that to symptoms, air quality, pollen levels, And indeed, we could use other particles such as fungus, which I'm sure is a major indicator. The outcome isn't thunderstorm asthma, that's too unpredictable, but asthma exacerbations, both mild, moderate and severe, and looking for them as the outcome to both create a window into not just thunderstorm asthma, but seasonal allergic asthma. So we look forward to undertaking that in the next few years. I owe a huge debt of thanks to Rachel Tham, who's put together so much of this work, and to our honour students, Hannah Murray and Prasanth Konduru, who analysed the prospective data and were able to undertake their case time analysis, and all the collaborators on the TASAR and Carista studies, which has been a huge body of work for us. So thank you very much for your time. I'll stop there.
Thank you very much, Jo. It's a huge body of work, isn't it? So we have a few questions in the chat, which I'll just go through. So the first question's for Sabrina. In terms of thinking about the emotional distress triggering allergy symptoms in those who live in closer to greenery, could the irritant effects be associated with that? And did the authors of that paper consider that? And I guess for those who live in Melbourne and maybe even Sydney, about the debates that go on about the plane trees and the effect that they have on people.
Yep, thanks, Rachel, for that question. So by irritant effects, you mean whether the authors consider the pollen levels in relation to the emotional distress? If so, they did not. So I think that's a limitation of the study. They did not actually look at the relationship between the pollen levels and the emotional distress. They just looked at the residential greenness and then their perceived allergenic trees near their residence. So it's more of a subjective measure rather than an objective one. So I think if a study does look at the objective measure in the sense that it looks at the pollen levels, that would strengthen the evidence more. So yeah, that was a limitation.
Thank you. Okay, so we have a question from Darcy. For Jo, this one. Could you clarify how thunderstorm asthma is defined? Is it based on the number of hospital admissions, pollen counts, or the occurrence of a thunderstorm event? And has there only been one thunderstorm asthma event in Australia, or have there been multiple occurrences?
Thanks, Darcy. So thunderstorm asthma is defined as a surge in emergency hospital presentations for asthma over fourfold from baseline, and it's an operational definition, if you like, that actually allows a healthcare response, identification of the emergency occurring. So it's not related to pollen counts, and it's not related to even environmental things, and it's not even related to thunderstorms. It's related to the surge in asthma presentations. Oh, sorry, in the setting of a thunderstorm, but it's in the springtime, so that's called thunderstorm asthma. But it's really related more to the surge in asthma presentations, which occurs in a very short time frame. So the second part of the question, I've always done, Rachel, what I do is just always forget the second question when I'm answering the first.
Yeah, has there been only one thunderstorm asthma event in Australia or more?
There have been many. The first well-described was 1984, which is 40 years ago. And Ronaldo Bonomo, some might know as the former director of intensive care at the Austin and now a very highly cited researcher, described it, and also collaborated with Bruce Knox, and being intensivist was very happy to get people to breathe in pollen and show that pollen didn't do much, intact pollen, but when they ruptured the pollen, they actually gave people pretty bad asthma in assessing the causation of it. Again, not the sort of experiment we do so easily these days. So there have been, we know they occur every 5 to 7 years, or at least they have, from 1984. And I should say the ones that have been reported are probably the least of them. For example, in 2016, there was a terrible one. 2017 had one that was just as bad as the 2010 one, but you never read about the 2017 one because it's sort of subsumed in our capacity to manage it. last year we had 2023, we had quite a bad event, which was again about 2/3 as big as the 2016 event, but not so big. So they happen regularly. I guess our capacity to deal with them means that they don't get so well publicised. And our emergency warning systems are much better, which allows everyone, both consumers and healthcare services, to be more prepared.
Yeah. Thanks, Jo. I've got some questions specific to ryegrass. So there's two. It's one from Michael, one from Julie. Ryegrass is an imported pasture grass, i.e. not an Australian species. Has there been any work with agricultural and genetic researchers to substitute less allergenic grass species or to develop less allergenic ryegrass GMOs? I assume that's genetically modified stock type.
Yes, indeed. So GMOs are being developed, particularly with attention to the major allergens, and particularly often the group 1, because that's considered the greater problem with hay fever. But probably for us and what we know now, we perhaps should go for group 5. Obviously, grasses are a major subject of agricultural research and development, and also different pastures for different purposes and different grazing purposes. So there's been quite a lot of work in that, but allergy often isn't so centre of mind, and that really focuses on the GMO work.
Yeah, thanks. And Julie comes from planning and urban and design of cities. There's a great push to reintroduce native grasslands, which are in critical decline. Do you believe that replacing grass species in urban areas would make a measurable difference? And as ryegrass blends are typically used in sporting playfields, and if pollen travels a long distance, then this feels like a challenge. I'm not sure if it's a comment or a question.
I think you're right, it's a challenge, because I suspect that thunderstorm asthma is probably due to the stuff carrying across from the Western District in Melbourne, as much as anything. But I think local exposure makes a difference. We see a lot of people from out west who just next to a field that's full of grass, ryegrass, and it'll be pasture grass, and they will be suffering. Now, we could use native grasses, which are far less allergenic, and they're not those temperate species. They're not as good pasture, and they're probably not as green, but they're really useful. I'm not so worried about sports fields, to be honest. They get mown. They don't really pollinate very much. They have to be sown and re-sown for that reason. And often they also use other species, particularly Bermuda subtropical grass, which has not really been associated with asthma, as you know, so much. So I'm less concerned about them, and I think we should just keep on doing what we're doing there.
I have one last one, and we've got to make it quick. Nick has asked, why doesn't Sydney have thunderstorm asthma epidemics? Yeah.
Sydney does, but Melbourne pollen counts are much higher than Sydney, and I've mentioned the importance of geography. If you go down to Wagga, they have terrible hay fever events. Canberra has terrible hay fever and thunderstorm asthma events. Sydney does, just not as bad. The other point is a lot of the grasses that grow around Sydney, and I don't know about agriculturally so much, are subtropical grasses, so particularly Bermuda, Bahia and related species, and that might also have something to do with it, because they don't have the group 5 allergens that are so important.
Thank you. As we've run out of time for this huge seminar, I'd like to conclude today's seminar, and I want to extend my sincere and deep appreciation to Sabrina and Jo for their excellent presentations on this topic. We hope that you've all found this information valuable and insightful, and if you have any further questions or would like additional resources, please don't hesitate to reach out to the Centre for Safe Air. We look forward to seeing you at our next webinar in November. The topic is still to be confirmed, but we will send out invites for this upcoming webinar soon. We wish you all the very best, and thank you for coming today.
Thank you very much.
Thank you so much. Bye.
Bye. Thanks, everyone.